So as one by one the gadgets are getting opened up now, let's go in a chip scenario where we have almost a patient with a bad coronary anatomy with comorbid conditions and associated cardiac dysfunction or LV dysfunction. If you see on the right slide, the coronary anatomy is something which always worries when the patient condition worsens because you got mechanical circulatory supports which can give hemodynamic compromise and you can stabilize the renal parameters or maybe other comorbidities. So only thing is when you have a complex lesion like a bifurcation, calcification or a CTO or something like a post-CABG where graft occlusion is there, and that is a situation where the patient condition also worsens, you need to give some results as early as possible with minimum complications occurring on table. If you see from the data from the syntax, almost 50% of patients in bypass surgery, more than 50% in bypass surgery had calcified heavy calcification. And angioplasty also is not different. Almost 50% have heavy calcification. And that is the situation where you have device crossing, balloon or stent crossing problems, balloon inflation problems, and getting a dog boning defect. You get your stents getting delaminated. You try atherectomy, there's a wire bias, doesn't cross. You get under expansion and unpredictable laser. Calcium laser also seems to be having issues. So in a very complex cases where the mechanical circulatory support or compromise is there, you try putting a long stent, always ends up in uncrossable lesions or undilatable stents. And when you do an imaging over there, you see you get a under expansion, edge complications, perforation, stent failure, the TLR, all the way changes. So definitely you need your weapons in your armamentarium, like cutting balloons, scoring balloons, orbital or rotatherectomy or laser, or even the IVL for better results. And imaging is the clue to give it if time persists, time gives for the mechanical circulatory support to act. But once you give an impella and all these things, you get enough time so that you can do an imaging, get the quantity of calcium, and do the procedure accordingly. Calcium is a major hurdle. If you see on the left side, almost you got a thick chunk of calcium at the distal left main and the ostial circumflex with almost an occlusion of the LED over there. So the depth, the arc, and the length of calcium is important in assessing, and imaging tools like the IVUS and OCT always are quite handy if possible to assess first what could be the modality which can be used as quick as possible and get the patient out. The importance of IVUS and OCT is the thickness as well as the arch of calcium. You see that OCT gives a better thickness as shadowing is not there as you see in the IVUS. And the rule of 5, everyone knows, like when you have an arc of calcium more than 90 degrees and a thickness of 0.5 and a length of more than 5, then definitely the score increases. And even the IVUS also has a scoring system which also has an extra on the arc of calcium. And once the score increases, stent expansion comes down, and that's what you see. So you need to prepare the plaque before deploying the stent for better results. And for this, lithotripsy was something which was used for the renal stone calcium cutting and which had come in the peripheral disease as an IVL and later in the coronaries. It all started in 2009 in the fall of where it was tried out in an eggshell where you can see that the egg shell cracks but the membrane becomes intact. And that was something all started with the peripheral IVL and slowly into the coronary IVL. So intravascular lithoplasty or shockwave balloon is something like this. It's a 12 mm balloon with 2 emitters which emits shock waves which can cut the calcium but not injure the intima. So this is basically an unfocused lithotripsy energy where, which the electrical energy can be converted into sonic pressure waves, and as the bubble expands, the acoustic pressure increases and cuts the calcium. So there can be different mechanisms for this fracture, from the compressive stress to the shear stress to the spall stress, as well as the tensile stress and the final, the skewing stress, which acts together, making this calcium crack. It's basically hard on hard in the sense like only the calcium cuts, but the intima doesn't get injured, and that is some advantage of intravascular lithotripsy. The catheter, C2 catheter, is quite user-friendly. It's a generator which can be just charged like your mobile in a plug, a connector which is easily magnetic, just connect it up, and the catheter also comes at a size from 2.5 to 4, and the length are always 12. The saline is basically the radio contrast is saline at 50% you add on this, and it basically causes the calcium cuts to happen up. The Disrupt CAD3 is something which was a great eye-opener. After the CAD1 and CAD2, Disrupt CAD1 and CAD2, which had 60 and 120 patients, this had almost around 380 patients plus, and a multinational trial in which they had taken cases where having more than 270 degree of calcium with imaging in majority of cases out there. If you see over there, severe calcified cases were taken up, and if you see on the last, you can see the stent delivery and the post-dilatation were seen almost more than 99% in majority of these cases. And the improvement in the diameter stenosis as well as the lumen diameter post-IVL as well as post-stent in IVL patients were phenomenal. And the most interesting part is the complications were quite negligible. Just like an atherectomy, there were no reflow, no flow, as well as AV blocks were quite not seen, and it was quite safe and user-friendly too. Even if you see that the device crossing or the angiographic success as well as the procedure success were always about 90 to 95%. So high procedure success, low complications, and that was the time when the IVL had hit the roll. So I'll just go with the case over here. This was a post-CABG patient who had a calcified proximal LAD occlusion calcified LAD where the lemma was occluded, and the SVG to the diagonal was giving the distal LAD flow. So the patient was symptomatic, balloons hardly crossed up, a rotablation was done, and you can see the lumen after the rotablation. And this is a 3 IVL balloon, and you can see the increase in the lumen area after the IVL and the entire chunk of calcium being cut over there. You can see the cracks, IVL cracks over there, and that's the post-rota, and this is the post-IVL. Significant improvement in the lumen area, which will not compromise for the stent expansion. So that was a final result. This is also a post-CABG patient with an RCA calcium. You got a occluded graft to the RCA. You do an atherectomy. You get the results like this. You do an IVL, and that's the final result. Huge chunk of calcium. This is another patient where you can see that from the mid-distal RCA almost seems to be having a lot of calcium over there. Difficult wire crossing, microcatheter crossing. Use a guide extension catheter, do an IVL, cut those mid-distal, implant stent, and that's the final result. Post-CABG patient, left main calcium, try with all non-NC balloons, doesn't crack, use an IVL, difficult to cross an IVL, and you can see the wasting in the IVL over there even after 80 pulses. Post-dilated with an OPN after that, and that's the final result. So conclusion, I would say IVL definitely is a new promising tool, especially for very severe calcified coronaries. The ease of assembling, crossing, side branch access can be kept. Delivering, especially in chip scenario, is quite important. Low pressure dilatation is the most key of it because of the complications arising with high pressure balloons are not seen. And the stent expansion and delivery seems better and easy. Thank you. And the most important part, no complications of atherectomy like no flow, perforations, or AB block. Thank you.
Dr. Jimmy, nice talk. Just asking it out. Do you routinely do in a workhorse wire or use an extra support wire for IVL?
No, like workhorse wire only mostly used out anyway.
Okay.
But the thing is, like if it's an uncrossable IVL, then maybe upfront atherectomy to be done out anyway.
We found actually extra support wire gives it better trackability, but I don't know many.
Maybe a distal lesions, I think maybe having a better extra support. But I think proximal lesions, I think once your 2 balloon or 2.5 balloon crosses up, do a pre-dilatation, then I think your IVL balloon will be easily. Once an OCT catheter also mostly crosses, I think the IVL also will cross. But distal, I think maybe an extra support would be beneficial.
Nice talk. Are there more chances of perforation compared to rota?
No, no chances of perforations at all.
Because of this.
It's only, we are only dilating up to 4.
After stenting. Because of the calcium spicules, they get. No.
Only the calcium gets cracked, but the intima is not getting injured out anyway. And thing is, like after IVL, it is always better to even post-dilate, before stenting it. So it can get opened up. But once you see that IVL balloon opens up nicely, and there is only the last case where even you had a dog boning effect with an IVL. There was so much chunk of calcium in the left main. Otherwise, like most of the time, like even after the first 20 or 30 shocks, even they can see that balloon uniformly dilated out. So I think the calcium has given way out anyway. Only thing is, one main advantage of all these things is the AV block is not there. The slow flow, no flow, you don't need to see. And chip cases like this, that is something where the hemodynamics worsens like any bad.
Have you encountered any arrhythmias?
No, at the ventricular, like whatever they say about the ventricular pause or whatever extra beats, definitely those things are definitely seen out there. But all these are benign things and it will recover once you're shocked. It's just 10-second shock, so it recovers back.
Yeah. Any situation where you think IVL could be superior to rotation, like standard?
IVL definitely, thing is always imaging would be a key in it. And if you have a moderate to severe calcification, especially severe calcification, I would say IVL would be better than a cutting balloon or a scoring balloon out. But when you have a superficial calcium, I think atherectomy still stays on.
Be under expanded stent.
Yeah.
Maybe we can.
Exactly, under expanded stent, you try using a OPN balloon or anything. If it fails, then especially an IVL is a game changer where you can do
without damaging much to the stent.
Exactly, good results.
Thank you, Dr. Jimmy. Yeah, one last one. Yes.
So, do you encounter any time any acute stent under expansion where you have built up with IVL?
Yeah.
Long-term data. Obviously it will work. Any long-term data, because we are giving multiple pulses with the high atmosphere, almost 55 bar. So, any disruption of the stent architecture, polymer, anything? Do you have any data?
No data as such. Anyway, 2 cases we have done where you don't have a, under expanded stent, and it was almost like no other balloons were able to dilate it up. But IVL was something, even in the first 20 shocks, just opened it up well, and it was well imaged too about it out. But injury to the stents, like what the ablation atherectomy, in that is not seen as such in IVL case over here, but maybe long-term follow-up could be required out in those cases.